Hello everyone, I'm Mike Stoto and I thank you for joining me for this presentation about learning from experience about public health emergency responses. When you think about the complexity of public health emergencies, I think that everyone will agree that the only way that we really know how well public health systems will respond in a future emergency is to see how well they performed in a previous incident. We have to ask some of the standard questions that we see in after action reports, such as how quickly cases were detected or how many vaccines were delivered. But we also have to ask how and why systems performed as they did, if we really want to learn some deep lessons that can be useful for the future. But asking these questions is challenging. The main question, the main challenge is that critical incidents are singular events. They're unique in their context, in their specifics. So we can't really use statistical measures to see how well systems have performed. There are other challenges as well. What we regard as the public health system is multifactorial and complex and fragmented. It includes health agencies at the global, the national, as well as the state and local level. And the structure and functions of these agencies vary at different levels of geography and from one place to another. This public health system also has many agencies and partners that are really not primarily health agencies. They're healthcare delivery systems, they're policymakers, emergency medical services, police and fire, civil society, media, and many other organizations in the communities that we serve. And with all of these players, it's not always clear who's responsible for what actions. Furthermore, an effective response is complex and multifactorial. All of these different agencies, depending on the emergency, have a different role to play, and it's not clear and effective it's not clear what is effective and what needs to be done. And even after the fact, we don't know what would have happened in the counterfactual if we had done something else, and whether that would have been better or worse. So the other thing we have to focus on is what do we mean by a critical incident? In our work, we've been uh, defining this as having three characteristics. One is that public health agencies played a significant role in the response to the incident. Second, the incident was meaningful, but meaningful can have a number of different meanings. Obviously, one of them might be the magnitude of morbidity or the social disruption involved. But incidents can be meaningful for other reasons as well. They could have revealed critical vulnerabilities in response capabilities of the public health systems. They could have called into question beliefs or behavior in the system. They could have helped to identify some best practices. Generally, an event is regarded as critical if it captured the public health emergency preparedness community's attention. The third characteristic is that an incident has to have the appropriate temporal and organizational scope to capture the event. If it's too big, there's too many different factors to be considered, and it probably has to be broken down into a number of particular parts of the overall incident, bite-sized chunks that can be analyzed carefully and thoughtfully. So in our work, we've come up with 7 different practices that we think can be helpful for critical incident reviews. To examine the incident from multiple perspectives, including external, to base the analysis on what was known at the time, to focus on the most relevant capabilities rather than the capacities, to focus on pivotal events, identify root causes, to build a critical incident registry, and to reward learning rather than punishing poor performance. In the rest of this presentation, I'll go over each of these things individually. The first practice I want to discuss is the importance of examining an incident from multiple perspectives. A typical after-action report done by a public health agency will look at its own performance, taking everything else as given. But an important factor to look at is how did the agency work with other public health partners at the local, state, and national, and maybe even global levels? And how did it work with some of the other components of the public health emergency preparedness system, healthcare delivery agencies, policymakers, EMS, and all of the many community organizations that play a role in any given incident? One way to help to bring this external perspective is to involve peer assessors from other agencies, maybe public health agencies in nearby jurisdictions that understand the context but weren't involved in the particular response that's being studied. Another practice stresses the importance of analyzing decisions based on the information that was, or at least could have been available to decision makers at the time. It's easy when we're analyzing these things after the fact, and we know how things turned out, to say, well, it's clear we should have done so and so, or if we had done that, so and so would not have made a difference. Um, the challenge, of course, is to put ourselves back in the situation that the people making the decisions at the time were making, and say, what is the right answer given what was known at the time. It's also important in analyzing critical incidents to focus on capabilities rather than capacities. What do we mean by these terms? Capacities are the resources that public health emergency preparedness systems have to draw upon. The infrastructure, the policies, the plans, knowledgeable and trained personnel, and so on. Capacities are like the ladders in this cartoon. Clearly, they're needed. The ladders are needed to get over the wall, but just having a pile of ladders is not enough unless you know how to put them together so you can climb over the wall. And that, in fact, is gets us to the capabilities. The capabilities are the actions that a public health system can take to identify, to characterize, and to respond to emergencies. Having the capabilities depends on having the capacities in place. You can't get over the wall with only without the ladders, but just having the ladders enough or not enough to do the job. You have to know how to put them together. Um, so preparedness capacities um, are the resources that the systems have to draw upon. They tend to be specific to local and national context, and there should be evidence connecting these capacities to the outcomes, but oftentimes that evidence is limited. Capabilities, on the other hand, are the actions that a public health system can take to identify, characterize, and respond to emergencies. These are more likely to be generalizable across incidents and settings. So we'd like to learn about things like um, how quickly did the system identify the first cases, and the systems that are available for doing that may be very different in a small community than in a large geographical area. But we have to say, but the job, the capability to detect those first cases is the same. Now, to help us straighten this out and to keep these things clear in our mind, we use a logic model. Logic models help to specify the goals and the objectives, the response capabilities and capacities that are needed to achieve them. They aren't really standards. They don't specify what's a sufficient response. But, but to the extent that there's evidence connecting capacities to capabilities to outcomes, we can then assess the capabilities and the capacities as proxies for the outcomes. Um, Logic models help us to identify what to measure, not how to measure it. They help us to ensure that important aspects are all covered, and the capabilities are specified in a way that's sufficiently general to be assessed in different situations and contexts, yet have meanings in others so that lessons can be transferred from one incident to another. So as an example of this, this is a logic model that we have recently developed for the European CDC, but it works, I think, in many situations as well. On the left, we have the capacities. On the right, we have the objectives. But the real focus here is on the response capabilities. We want to have systems that are able to detect and to assess an incident from the outset, to develop policy and adapt and to implement existing policies and practices. And that focuses on delivering health services, preventive services, dealing with medical surge, and so on. The first three are the key capabilities that are substantive capabilities that are needed. But we also recognize that in order to achieve them, systems need to be able to coordinate and to communicate within the public health system for crisis management and communication with all the relevant agencies, and they need to be able to uh, do emergency risk communication with the public as well. The fourth practice it stresses the importance of focusing on pivotal events. And here I'd like to give an example. The example comes from the emergence of the H1N1 pandemic in 2009 in North America. And in order to study this after the fact, we first created a timeline that was based on scientific literature, on websites, on news reports, and other key informants. And we represented in this timeline the emergence and the spread of the virus, about local health officials' awareness and understanding of these, and also the notifications and awareness that was done at the national and the global level. And I'll show you that timeline in just a moment. But through that work, we identified three pivotal events where the story could have gone very differently. Um, One was the identification of this new pandemic virus in two children in California. Second one was the recognition that apparently unconnected outbreaks throughout Mexico actually were connected to this new virus that emerged in California, was first seen in California, and represented a public health emergency of international concern, uh, which triggered the involvement of the World Health Organization. And three was the identification of the same virus as responsible for an outbreak in New York City high school students. So here's the timeline. There's a lot of detail here, but the things to focus on are the colors of the different boxes in the calendar. Green corresponds to Mexico. The light green reflects what was actually happening in the epidemic itself, and dark green in terms of what Mexican officials knew about what was happening. Light and dark blue are the same, represent the same things for the United States, and yellow represents communication among the U.S., the Mexico, Canada, and other WHO and other countries. A couple things are evident from this analysis. First is that there were cases as early as February 22nd, and maybe earlier, that were not known about until at least 5 weeks later. So the virus was actually in circulation for a good time before there was the opportunity to intervene at the national or the international level. The second point is that there was a 2-week period in April in which Mexican and American officials were both aware of something that was going on in their own country, but didn't realize that the two were related, and that it was reflected the outbreak of a new influenza virus. And third, what this means is that under the best of circumstances, it might have been possible to mount a response a week or two earlier than it actually happened, but that at that point the virus had already spread around the world. Now, actually, that reflects quite a substantial victory. The in past years, it probably would have taken substantially longer to detect a new pandemic virus. Now that gets us to the fifth point, which is to identify root causes. I think continuing with the H1N1 example, I think one of the things that we found here is that investments in the global surveillance notification systems have made an important difference in our ability to respond in 2 weeks rather than 2 months or longer. And what actually made up that response? Well, the first, there was enhanced laboratory capacity both in the U.S. And Canada, as well as a trilateral agreement between the U.S., Canada, and Mexico that allowed the Mexican authorities to share samples with Canada and the U.S. To confirm that the virus circulating in their country was the same as in the U.S. Secondly, there was improved global notification systems. This too is a capacity. It includes systems like GFIN and HealthMap and ProMed that allow epidemiologists and public health officials to share information around the world. It also includes the international health regulations that promulgated in 2005, which include expectations, indeed obligations, that countries share information and not suppress information about outbreaks of potential global importance. And more generally, the social capital, the networks of epidemiologists, public health officials, laboratorians, and others who were sharing both had incentives to and had the ability to share information about what was happening. But I think that beyond that, there also are enhanced assessment capabilities that include the ability to recognize an incident and to characterize the risk that didn't exist earlier. And this enabled earlier development and deployment of a pandemic vaccine and other local, national, and global public health responses. Let me give another example of root cause analysis having to do with Ebola in the U.S. in 2014. Just a brief timeline. The first case that we know about emerged in Guinea in December of 2013. And the outbreak was detected and known locally in 3 countries in West Africa between January and March 2014, but it was thought to be cholera or some other condition. And it wasn't until the second half of March when Médecins Sans Frontières, Doctors Without Borders, notified the WHO, and they confirmed that it was Ebola virus responsible for the illness that was spreading. Despite this notification, between January and August, the outbreak spread in those 3 countries, and it wasn't until August 8th that the World Health Organization declared a public health emergency of international concern. Now, in the U.S., there was general awareness of that really heightened in August and September. First, when 2 American healthcare workers who had been working in Africa came home and were treated for Ebola at Emory in Atlanta. At that time, the CDC was projecting up to 30,000 deaths, and President Obama decided to send U.S. troops to Africa to help in the response. And the news was media and medical literature was saturated with information about Ebola. In the month of September alone, the New England Journal of Medicine had 9 separate articles or pieces about Ebola. And so people were well aware of this. And furthermore, around the country, state and local health departments and hospitals were distributing guidelines on case recognition and treatment and maintaining communication with one another. Well, how well did this work? Well, the first case was Mr. D, who was a Liberian man who left his country on September 19th. He then traveled to the U.S., and on September 25th in the evening, he developed fever and abdominal pain and nausea and headache, and arrived, and his family brought him to the emergency department at a hospital in Dallas. During the time he was there, he told one of the nurses that he was from Liberia. However, that didn't get to the physician who was treating him, and they decided that to send him home. 3 days later, on Sunday, he was much sicker. At this point, his family called the ambulance, where he was brought to the hospital with symptoms of Ebola virus disease. At some point that day, he was considered a potential Ebola case and was isolated in the emergency department. And the staff at some point started using personal protective equipment. But it's not clear from the record at what point on Sunday all of this happened. There was also contact made with CDC and the state and local health department, but it took until the next day, Monday, September 29th, until CDC and the state health department agreed to receive samples and test them for Ebola. And it wasn't until the next day, the 30th, that positive results came back. And at that point, the public health response was initiated, contact tracing was done, and family was quarantined, and that was all undertaken. It took 5 to 6 days between when Mr. D first arrived at the hospital and when the public health response was initiated. Now, in contrast, let's consider a case that happened in New York City a few weeks later. This is Dr. N, a physician who had, an American physician who had been treating Ebola patients in Guinea, working with MSF. He treated his last patient on October 12th. He came home via Brussels. He had no symptoms. On the 21st, he had a bit of fatigue but no fever, and on the following day, the 22nd, he traveled throughout the city, including going bowling in Brooklyn and dining at the meatball shop in Lower Manhattan. The next day, October 23rd, he woke up with a low-grade fever, and following the protocol that he had been given, he called a special number, and a specially prepared ambulance brought him to the Bellevue Hospital Center, where a isolation ward was ready, and he was brought in not through the emergency department, but in a special route to minimize other patients being infected. Two of his friends were quarantined, and by that evening, there was a press conference with the mayor and the New York City Health Commissioner and others explaining what had happened and what was being done. The very next day, contact tracing begins, and the mayor reassured the public, and indeed there were no additional cases. Unlike Dallas, when two nurses were infected by Mr. D's case. Now, all this between when the symptoms first appeared and when the public health response was underway was less than 24 hours rather than 5 to 6 days. Now, the question is, could the public health response in Dallas have been more like New York? Well, it's not a totally fair comparison. The first case, of course, is always harder. And in the first case was also a physician trained by Doctors Without Borders compared to an uninsured traveler from Africa. But various people have suggested that, for instance, a better information technology in the hospital or connecting the hospital to public health would have made a difference. Well, maybe not, because in fact, Mr. D did say he was from Liberia. That was noted in the record, but it was not seen or appreciated by the physician treating him when he came to the hospital the first day. How about laboratory capacity in Dallas? Would that have made a difference? Well, again, probably not. There were the facilities to test a sample in Austin, only 200 miles away, and CDC in Atlanta. The problem wasn't the lack of facilities for laboratory facilities. It was the lack of a protocol for transporting samples and an agreement that this should be done. How about designated Ebola hospitals? A system that was set up after these two cases in 2014. Well, that may be useful if there were many cases, but it actually doesn't help to recognize the first case. No, the problem actually was the hospital's delay in identifying Mr. D as a possible case and alerting state and local health departments, as is expected. These first three things, information technology, laboratory capacity, designated hospitals, are all capacities. They could be useful. They might have been useful in other stages of this outbreak, but they didn't make the difference here. What the notification between the hospital and the health departments is a capability, and that's really what was lacking in this case. So what does the root cause analysis tell us here? Well, when Mr. D developed symptoms, three things needed to be done. First of all, obviously, to treat his condition. And secondly, protect others in the hospital environment. Neither one of those things was done quite as quickly as it should have been. But the third one, which is important for protecting the rest of the population, is to initiate a public health response, including contact tracing. None of these things were done when Mr. D came into the hospital on September 25th, and even after he came in on September 28th, 3 days later, there were some hours or perhaps a day delay in initiating the public health response. So what's needed here? Well, first of all, hospitals and healthcare professionals must recognize that they have public health responsibilities. These include detection and assessment, and their responsibility to coordinate and communicate within the public health system. What this means is that we really have to address these capabilities by planning, training, and drilling as a public health system, including healthcare workers and hospitals, and build the social capital that's needed for that aspect of the response. The sixth practice that I'd like to focus on stresses the importance of building a critical incident registry for public health emergency preparedness. Aviation and other sectors have shown that a registry concept actually can be very helpful in improving outcomes, particularly when you have rare events. The concept would be that we would create a database of incident reports filed by public health agencies that responded to a critical incident. The objective would be to drive organizational development through careful analysis of a health department's own events, to facilitate identification and sharing of best practices across public health systems, and also to provide a database that would allow researchers to do cross-case analyses to identify the context and mechanisms that determine success. And what would this look like? There would be a report structure that facilitates the analysis of both individual incidents and supports cross-case analysis. We need a structured summary, searchable by practitioners looking for best practices in situations like their own, and for researchers looking to identify trends across incidents. And the report should include enough about the context, the characteristics of the responding public health system, including the history and training, so we can understand and analyze the case. The report should also include a timeline of pivotal events in the incident and an analysis of public health systems' role. And particularly, we want to focus on public health emergency preparedness capabilities that were tested at a high enough level to allow generalization. We have to talk about the capabilities so we can generalize from one an incident to another. So, for instance, in the Ebola case we spoke about, the issue wasn't what happened with Mr. D on a particular day. It was identifying that the need to have better communication between healthcare providers and the public health agencies in their jurisdiction. And these reports should have just enough detail to understand why particular mechanisms worked in that context. So that requires standard definitions of both context and capabilities. Finally, I'd like to stress the importance of rewarding learning. There are a number of barriers to critical incident analysis and reporting of the type I'm speaking about in this presentation. The time it takes to do it, the effort, and whether or not staff have the skills needed to do it. And there's also, frankly, the concern about embarrassment or liability if a health department airs its dirty laundry, as sometimes people say. So this can be addressed in a number of different ways. In the aviation industry, there are mandatory reporting and penalties for not doing so. I'm not sure that makes sense given the nature of the public health system that we have in the United States. But it could be a condition of funding from higher levels. When CDC funds state and local health departments on emergency preparedness, they could be expected to do critical incident reports when they have events. And of course, it could be purely voluntary. And particularly as we're thinking about voluntary or conditional on funding, we need to think about the incentives for this. And that needs to begin with clarifying that the goal of this is not to place blame, but rather to learn as an organization about what works well. So that requires that we provide support, such as a tool for doing root cause analysis and training on how to use it. That involves facilitating peers to help with this analysis and to share information by doing that. and schools of public health and other academic organizations that might help to provide the kind of analytical support that's needed to do this kind of critical incident learning well. And then finally, we need to reward insightful reports rather than a health department thinking that it may be embarrassed by saying something. We need to actually maybe give an award or publish in a journal some of the more interesting or insightful reports that come out of this. So I'd like to conclude by thanking some of the colleagues that I've worked with on this, and for the U.S. Centers for Disease Control and Prevention for research support here. If you're interested in more information on this topic, the Harvard website has a number of toolkits and other resources for critical incident reports. And I'd also like to call your attention to a book that we published using some of these techniques to look more carefully at the public health system response to H1N1 in 2009. Thank you.